All right, you guys, hello. It's Dr. Green. Sorry for the blurry background. Thank you for your patience as well this week with our Katie site visit going on. This is the lecture for knee ligamentous pathologies. Sorry for the blur on the camera here. I do apologize. Let me share my screen and we'll get rocking. So guys, once again, this took me a little bit. This took me a hot minute to put this together. And this is a beefy lecture. So I want you guys to spend time with this video, right? Spend time watching this. There are some YouTube videos, excuse me. There are some YouTube videos that are part of this lecture that demonstrate some mechanisms of injury that I want you to take a peek at. And I'm gonna walk you through those as we go through this together. But right, this is going to be a very, very important lecture. So essentially the task this week is I want you guys to review this up to Friday. Please watch this. And then I'm just going to post a brief quiz for you guys. And I'll leave that open until Saturday night, but that will be up this evening as well. Okay, so here we go. Okay, so obviously, guys, we've been spending a lot of time, right? And we've kind of introduced it in class, talking about the knee, right? Things like the articular surfaces, and we've really been mainly focusing on the ligaments. But okay, so we have the surface of the femur, right, and the surface of the tibia. Those are covered in articular cartilage. Excuse me, I've been coughing like crazy today, so if I cough, I apologize. And obviously, the purpose of the cartilage is to decrease the friction and pressure on joint surfaces, right? A little different from the menisci, which increase the contact area, and we'll learn about that as well, right? But what about the ligaments? The purpose of the ligaments is to serve as a primary restraint to movement of the tibia on the femur, right? And so the ligaments of, excuse me, of the knee, the main ones, are organized into groups. The cruciate ligaments, I am sorry, the cruciate ligaments being the ACL and the PCL, and then the collateral ligaments being the MCL and the LCL. Okay, so you can see here, a little picture. This is a posterior view. Here's a lateral side. We have the LCL, the medial side with the MCL. We have the PCL here in the back, and then just in front of that, you can see the ACL. Okay, so what about the ACL? Pardon me. Let's do a deeper dive into the ACL. So the ACL obviously has its origin right on the intercondylar notch of the femur, and you can see it's on the back side of the femur here, right? Now, this obviously inserts, as we've already talked about, more anteriorly on the tibia, right? So it inserts on the anterior aspect of the tibial plateau. So the ACL is organized into two bundles, right? One ligament, but it's made up of two bundles, right? We have the anterior medial bundle and the posterior lateral bundle. So the anterior medial bundle obviously is going to insert in a slightly, within that ACL insertion on the tibia, it's going to insert slightly more anteriorly and medially, and the posterior medial bundle, posterior lateral bundle, I'm sorry, that's a typo there, is going to insert more posterior laterally. So those attachments, right, of the ACL onto the tibia, where that attaches is called the tibial footprint. So the attachment of the ACL onto the tibia, that spot is referred to as the tibial footprint. Okay. Conversely, okay, the ACL, the origin of the ACL at the femur, right, is referred to as the femoral footprint of the ACL. Okay, so we have the tibial footprint on the tibia and the femoral footprint on the femur. Okay, what about the biomechanics of the ACL? What does it do? So clearly, the main purpose of the ACL is to, first and foremost, inhibit anterior translation of the knee, but also is also meant to act as a restraint to rotation as well, right? So there's another mechanism that we need to be aware of, right? And so when the knee is fully flexed, so sorry, the ACL is under the least amount of tension possible, right? And it's under maximal tension and full extension. So that difference in tension and essentially the the relaxation of the ACL fibers and flexion, and the tensioning of them and extension, right, is called the screw home mechanism. Okay, and that occurs as the tibia and the femur rotate around each other during full flexion and extension of the knee. Okay, so while the knee is a hinge joint primarily, there is definitely also a rotational component to it. Okay, and I know I'm moving kind of fast here, but what about ACL injuries? Okay, injuries to the ACL. Usually we divide injuries to the ACL into two types. The first type of injury to the ACL is a contact injury. Okay, that's where, the patient, the athlete, someone hits them in the knee, runs into them, and they tear their ACL, due to a contact force, right? So usually, what happens is there is excessive force put through the knee at the time of contact. Can generally be in a valgus direction and or even a translational or rotational force, right? But because of the high velocity of that force, generally speaking, we will tear the ACL through that contact mechanism, right? And it's not uncommon with contact ACL injuries to also have concurrent injuries to the MCL, even the meniscus, right? And, obviously more than one ligament with those contact ACL injuries. Okay, on the flip side, the ACL can also be injured through a non-contact mechanism. Okay, sorry, and that happens obviously with something like planning, twisting, landing, or trying to change direction. I have a couple of videos here in a minute that are going to kind of show you these different mechanisms. Okay, and I want you to pay really close attention to that, and kind of take a look at what happens with each of these. Okay, so with the non-contact mechanism, though, right? Excuse me, this can happen when landing from a jump, right? And generally speaking, the knee will rotate excessively, which then causes the knee to essentially go into an excessive valgus force, which puts pressure on the ACL, or tension force on the ACL rather, and a shearing force, which causes the ACL to tear, right? So the one thing is that it's a more common in non-contact injuries to see isolated ACL injuries. So where just the ACL is torn, the other ligaments in the knee are fine, right? So that's generally more common with non-contact injuries, but you can still have multi-ligament injuries and a non-contact mechanism as well. Okay, this is a contact injury, okay? And what I want you to do is I want you to pay very close. So once you see the quarterback in this video, Joe Burrows, keep your eyes on his left knee, okay? This is a contact, very obviously, kind of classic mechanism for a contact ACL injury. Look at what happens here. This has been slowed down. Okay, you don't see him yet. Okay, here he is. He's coming into the right part of your screen. Look at that left knee. Boom. Let me back that up. Okay, let's look at that again. Keep an eye on the left knee of Joe Burrows. You can see the defender comes in, hits him in the left knee. That is an ACL tear, right? And also likely potentially, could also be obviously a multi-ligament injury there as well, potentially maybe an MCL, maybe even some meniscal involvement, okay? So somebody hit him, right? High energy force through the knee that caused that injury. Okay, next one, okay? This happens very quickly. This is a non-contact mechanism, okay? And by comparison, guys, the one thing that you'll see is many of our female sports, basketball, women's soccer, right? Many of them actually have higher rates of non-contact ACL injury, right? This has been an ongoing area of research for a long time. We really don't have a solid answer to this question even still as to why ACL injuries are more common in women than they are in men, right? Particularly non-contact injuries. So let's take a look at this video. Okay, this injury is going to take place in the first few seconds. Keep your eyes on number 5 here, all right, throughout the video, and watch your knees, okay? Here we go. Dribbles, changes directions, boom. All right, one more time. Okay, so here we go. There's the stop, and she tries to change directions. Boom, right there, left knee. Okay. Very common mechanism for a non-contact injury right there. Okay. Okay, here we go. And we'll learn more about this, obviously, as we continue to kind of move forward with this class. But how does an ACL injury present, right? So we saw the mechanisms that can happen, right? And so a patient may come to you, telling you that their knee hurts. Oftentimes, and what you saw there with the second video, it happens, but it's not as common that these people will simply just walk off the field, right, or the court. You typically have to go out and get them, right? So they're going to complain of obviously diffuse knee pain, and this is different with everybody. Pain levels will be different, right? But a key thing here, a key symptom that they'll report is that the knee feels unstable. The knee feels weak or wobbly, and so you'll need to ask them as an athletic trainer, knowing what happened. Hey, does your knee feel does it feel unstable? Does it feel weak or wobbly? And they'll tell you yes or no, right? So oftentimes, these patients are going to tell you with an ACL injury that they felt a pop in the knee, okay? Now, contrary to popular belief, that pop that they feel at the time of injury is actually not ligament tearing. That is actually the lateral tibial plateau running into the lateral femoral condyle, right? That's actually two bones banging together. And that actually produces a very characteristic bone bruise pattern on MRI. Right? I don't have a picture of that in these slides, but we will go over that obviously when we talk about imaging. Okay, so obviously, patients that obviously had ACL insufficiency, that have torn their ACL, and the ACL is insufficient, it's no longer doing its job. Right? It's not serving its biomechanical purpose. Right? They'll generally have a positive anterior joint and a positive Lachman. There is a test that you can utilize called the pivot shift test. You're going to see that here in a second. You're going to see an exam under anesthesia. Okay. Here's the thing though. Remember back earlier in this semester how we talked about how certain injury nomenclature and classifications don't apply in every case. What's one exception that we gave? It was ACL injury. Okay, because ultimately, remember, the ACL, right? It has a blood supply, but albeit a very limited blood supply, right? And it is extremely difficult. The ligament itself doesn't heal, right? And because the ligament itself does not heal, has a very poor blood supply, and we don't have the ability to preserve the function of the knee in a lot of cases, right? So if the ACL is not serving its purpose, that patient will have lasting functional consequences, whether it's a grade 1 sprain, 2 or 3, right? So the ACL is kind of where one of the cases where we depart from that traditional nomenclature of a first, second, or third degree sprain, because an ACL injury is a different injury in the sense that it has very functional consequences for the patient, and that grading system is inconsequential because 90% of the time the treatment is going to be surgical reconstruction, right? So here we go. Now, remember, we talked about this earlier in the week, right? The degree of translation that you're going to find on your ligament is going to vary. But remember, what's the key? The key to any ligamentous exam is symmetry. Does it feel the same on both sides? And do they have an endpoint? Do you feel an endpoint? Yes or no, right? So another thing, obviously, we want to make sure that we do Varus Thrust, both at 0 and 30 degrees. Here's a little bit of a pearl, right? Laxity, if you feel laxity in full extension, okay, that can indicate a cruciate ligament injury, generally an ACL injury, depending on the mechanism, right? Sometimes PCL. Remember this, guys. We talked about this on Monday, I believe. take a good history, listen to the patient, and focus on the mechanism. What happened? Okay, remember that if somebody falls on the knee, directly on the knee, they can have a PCL injury. With a Ligament, they can translate a lot more with the maneuver, but they'll have an endpoint. With an ACL, they will not have an endpoint, right? And that endpoint will be asymmetric when compared bilaterally. Okay, here's an exam under anesthesia, guys. This person is about to have basically a revision reconstruction, but they're experiencing obviously continued insufficiency of the ACL. Look at this exam under anesthesia. He's going to do a Ligament and a pivot shift. Okay, so a little bit of a kind of added commentary there. The pivot shift maneuver, which we will learn, we'll add that test in. If you remember, guys, remember what's the job of the ACL? It prevents anterior tibial translation and limits rotation, right? So ultimately, when the ACL is deficient, right, and not doing its job because of injury, there will essentially be, right, excess rotation, generally externally. So as you put someone in valgus stress and flex the knee, the tibia will reduce into internal rotation generally. Okay, so but don't worry, we'll learn that test in class. Okay, the PCL. Okay, so let's talk about the anatomy really quickly. Okay, the PCL is the posterior cruciate ligament, and just like the ACL, it also has bundles to it, right? So we have the posterior medial bundle and the anterior lateral bundle. Okay, now one thing you'll notice, if you look at this picture up here on the top left, the one thing that you'll notice is that in order, for the purposes of kind of illustration, they've cut this tibia in half long ways, right, with a saw, right? So what they're wanting to show you here is the origin of the PCL along the medial aspect of the intracondylar notch of the femur, right? And as you can see, right, here the PCL comes down. This is an anterior view. The anterior lateral bundle and the posterior medial bundle come down together and insert on the posterior aspect of the tibia. Okay, here they go. So they're originating on that medial, on the medial aspect of the intercondylar notch, coming down and attaching on the posterior aspect of the tibia. Okay. So the PCL, what does it do? A lot like the ACL, right? It's going to serve as the primary restraint, though, against posterior translation. So translation of the tibia backwards, right? And it's also going to contribute to rotational stability and knee flexion, particularly past 90 degrees, right? So the PCL, right, helps us restrain internal rotation and knee flexion, right? So the PCL, interestingly enough, is the largest cruciate ligament. It's bigger than the ACL, right? And because of that, it has a lot more tensile strength. Meaning, like if they were to pull on it this way, right, that it would take a lot more force, a lot more pulling force, or tensile strength to rupture that PCL as opposed to the ACL. Okay, so it's big and strong. Okay, how does someone injure their PCL? Here's the thing, okay? There's a common mechanism and then maybe a less common mechanism, okay? So the first one, okay, injuries to the PCL usually involve a fall onto the knee or a blow directly to the anterior knee. You can see in this first picture, this gymnast that we have in front of us, maybe over-rotated on, her routine, on a stunt or part of her routine, and has landed directly on that right knee, as you can see. Okay, now she's landing directly on that right knee, but the force that is coming back up through the knee from the ground will actually take the tibia and push it posterior. Okay, that could be enough to cause a PCL injury. Okay, particularly if that happens very quickly, like in this case. So obviously, A mechanism that's less common, right, is look at the bottom picture. I couldn't really find a good picture that I wanted to show you, but if you can see, right, this guy has presumably slipped and or something, but look how the right knee is hyperextended in the air, right? It's fully extended. Potentially he's lost his footing, or maybe he has, been kicked or, hit in the back of the leg. That's caused the knee to hyperextend rapidly. Okay, rapid hyperextension from a posterior to an anterior direction, right, can cause the PCL to rupture as well. Okay, so patients oftentimes with a PCL injury, much like the ACL, they're going to say, my knee really hurts and it feels wobbly. It doesn't feel right. It feels unstable, right? Here's the thing. Okay, you're going to use your exam. You're going to use your anterior drawer, your posterior drawer, your Lockman. Okay, what you're going to notice with that posterior drawer, okay, is the lack of an endpoint with the posterior drawer. Remember, with a Lockman with a PCL injury, they will translate more anteriorly because the tibia has fallen backwards, but they will have an endpoint, okay? In the event that they have a high-grade PCL injury, you may notice what's called a Varus Thrust, or the knee kind of jutting outward when they walk, okay? And that means that with a high-grade PCL injury, they may also obviously have disrupted some other lateral stabilizers and develop some posterior lateral instability. So, and as we talked about, pay close attention to your Lockman, take your time on the exam. Okay, what about examining a PCL? So remember those tests we talked about in class, right? So we need to be very careful with our observation, right? So look for sag. We need to look for tibial sag, right? And we can do that by comparing bilaterally. Remember when we picked both of the legs up in the air and looked at them to see if they were even, right? If one of them had sagged or not, right? Or, we can put the patient up at 90 degrees of flexion and look for a sag at the lateral tibia or a step off there, all right? Obviously, other special tests that can be performed, posterior drawer, right? The dial test. Okay, remember, we talked about how the PCL is also a primary restraint against internal rotation. So with a dial test, generally speaking, if someone has a high-grade PCL injury, they're going to have increased internal rotation, okay, because they disrupted the PCL and have less restraint into internal rotation because the PCL is insufficient, okay? And then the other test we learned in class was the quads active test. Okay, this is, maybe considered more of a detail probably by most people, but this is important, okay? There are ligaments that actually run near the ACL, near the PCL, and they're called the meniscofemoral ligaments, okay? And I made a little joke here and there. They're small but mighty, right? So the meniscofemoral ligaments are two little small ligaments, okay, that run on the front and the back side of the PCL. So here's my PCL, okay? My two fingers here is my PCL. Here, facing you, is my anterior meniscofemoral ligament, and facing me on the back side, posteriorly, is my posterior meniscofemoral ligament. What do they do? Okay, so my anterior meniscofemoral ligament, this guy, okay, this guy's name is the anterior meniscofemoral ligament, or the ligament of Humphrey. Okay, posteriorly, back here towards me, okay, on the back side of the PCL, okay, is my posterior meniscofemoral ligament, or the ligament of Risberg. All right, now that we know those names, we need to understand that they originate on the femur, essentially on the medial femoral condyle, and come across the PCL, okay, and on the anterior and posterior sides, and connect or insert on the lateral meniscus, okay? Why is that important? Because if you can imagine for a second, okay, the knee flexing and the posterior meniscofemoral ligament, or the ligament of Risberg, putting a little bit of a stress on the posterior horn of the lateral meniscus and closing off the circle as the knee flexes, right? And then when the knee is extended, right, the anterior meniscofemoral ligament, or the ligament of Humphrey, right, putting a little bit of essentially stress on also on the anterior horn of the meniscus to kind of open the circle up a little bit, right? So it actually changes slightly the shape of the lateral meniscus and also stabilizes the lateral meniscus on the tibia. And a lot of people, if these ligaments are disrupted, the meniscus can slide out of the joint space. We're going to learn about another pathology soon called meniscal root tears, where essentially the attachment of the meniscus to the tibia has come loose, and the meniscus starts to then slide out of the joint space or extrude. We'll talk more about that. The funny thing about these femoral ligaments, right, is that we know what they do, right? They kind of provide dynamic stability to the lateral meniscus, and they aid the PCL, right? Also a little bit in its movement through flexion and extension, right? Provide a little bit of added stability to PCL as well. Now, a crazy thing, anatomic studies have actually demonstrated that these ligaments are absent in 20 to 50% of people, and that tends to actually vary based on ethnic group. Really crazy. So some people would consider these ligaments to be actually anatomical variants. So they're not present in everyone. Okay, MCL. Moving right along, guys. So we've gotten through the cruciates there. Let's talk about the MCL. So the MCL, obviously, as we know, originates on the medial femoral condyle. It runs distally, okay, over the medial joint line, and attaches on the distal, basically on the tibia, below the tibial plateau, right, and just behind the pes serine. I'm throwing some crazy anatomy terms out from when we went over knee anatomy prior to spring break, right? So review these, okay? The MCL is the primary restraint against valgus stress to the knee. So remember, a valgus stress is anything that comes from the outside and causes the knee to open medially like this. So the MCL is the primary restraint against that. Now, one thing that's super important to know, the MCL is actually fairly thick, right? And it possesses two main layers. It has a superficial layer, okay? And that's my primary restraint against valgus stress, but it also has a deep layer. And that deep layer actually has an attachment, right, to the meniscus through these little tiny ligaments called the meniscofemoral ligaments, right? And the meniscotibial ligament. So these little tiny ligaments connect the deep layer of the MCL to the meniscus, right? So it's really important to know that people that have high-grade MCL injuries, they have a lot of laxity on their exams, so on and so forth, may also have a meniscal injury along with that MCL injury, particularly if they're demonstrating mechanical symptoms, locking, clicking, catching, feeling like the knee is getting stuck, along with obviously that MCL injury, okay? So what about people, and you do see this from time to time, that have had a lot of MCL injuries? They've had 4, 5, 6 throughout their career. So there are times where the ligament actually starts to almost calcify, right? And we develop this bony calcification on the bone known as a Pellegrini stiata, right? Kind of a big word. No, it's not a sparkling water brand. It is a basically calcification of the femoral aspect or femoral attachment of the MCL, right, onto the femur. And sometimes this can be painful for people. And so we call that Pellegrini stiata syndrome. Here's some pictures. Okay, so really kind of hard to find, but you can tell here if you look at the MCL. Here's kind of a picture of the MCL in real life, right? So this guy, they've opened up the medial knee. They're actually doing a brace procedure here, which we'll talk about in a second. So you can see the MCL kind of running through here, this kind of thick ligamentous structure. Because of the injury that's present, it's actually kind of flipped up. And so if you look real careful, it's actually right here. Okay, and you can see the MCL kind of runs from the femur, obviously, all the way down to the tibia, right? So if you look, okay, here's on this MRI picture on the left down here where my cursor is. If you look real close, you can see this MCL and how it's been basically a little bit disrupted. You can see the bright white here on the inside of the knee, right? So this is generally indicative of swelling, right, and fluid. So you can see where this MCL has actually been disrupted a little bit. All right. So on this X-ray too, this is actually an X-ray of someone with an MCL injury, and you can see how widened the medial joint space is. and how it looks like it's almost gapped open, right? So pretty interesting there, okay? And here, if you look real close, there's a Pellegrini striatum right there, okay, right at that femoral attachment of the MCL. So this is someone that's obviously had many MCL injuries. And if you look up here, there it is, a Pellegrini striatum right there on the femur. Okay, what are these people going to present with? So if we look at this picture, right, and this is, you know, one example where this can happen. You see this a lot in football, where someone comes in to tackle and ends up contacting the outside of the patient's knee, right? So they take a blow from the outside of the knee, right? And like we said, that causes the knee to open up medially, valgus stress, okay? And that causes a shearing or a stretching of the MCL, right? So you can have a non-contact MCL injury, but those typically involve a lot more rotation and valgus stress. Those are a lot less common. You will see them occasionally, but generally speaking, they're not as common as contact, right? So generally, patients are going to be really tender over the medial knee, over the medial joint line specifically, right? They will have laxity with valgus stress at 30 degrees. So obviously, if, let's say, for example, with a grade 1 MCL, they might be tender there and might be painful, but won't really have a ton of laxity and or any at all, right? With a grade 2, they'll be painful, a little bit more laxity, right? And then with a grade 3, they'll be tender over the medial joint line and have considerable and or gross laxity with valgus stress, okay? And obviously, remember, at 30 degrees of valgus stress, we're checking the MCL specifically, and in full extension, we're checking for potential cruciate ligament injuries that may also be occurring there as well. And obviously, it goes without saying, you should also make sure that you're checking the ACL, right? Checking your cruciates and just making sure that all the other ligaments are intact. You don't want any surprises, okay? All right, so this is one injury that we can really kind of talk about management. So MCL injuries, the vast majority of the time, I would say 90% of the time, particularly if they're isolated, are managed conservatively. All right, so we're going to use a hinge knee brace and weight bearing restrictions, so crutches, you know, to kind of keep them off the knee initially, and some rest size compression elevation, etc., to calm down pain and you know, and help with any edema formation. And then obviously, when we talk about rehab here in about a week or two, we'll get into, you know, priorities like quad activation, regaining range of motion, those types of things, right? So a general rule, and this is not hard and fast, but how long will it take someone to come back from an MCL? So 2 weeks times the degree of injury. Someone with a grade 1 MCL, you know, it's reasonable that they could be out for 2 weeks, right? Grade 2 could be a 4-week type of injury, and a grade 3 could be up to 6 weeks. But remember, this is more of a rule. This is not patient specific. So make sure that you're making a clinical decision based on the patient, on their values, and obviously on the characteristics of the injury, right? Of the pathology. So one thing to mention is that there actually is a surgery that's gaining more acceptance for MCL injury, and that's called basically internal bracing, right? And so ultimately what they do here is they will go in and insert essentially anchors into the MCL. So they will go in and essentially tie sutures into the MCL, and they will then essentially reapply tension on the MCL and tack the the MCL back into the tibia, right, and femur, utilizing anchors. And then they may also put some kind of tape over the MCL as well to kind of reinforce that. So that is a procedure that's getting more acceptance. I did work with a surgeon at TRIA that did do this occasionally, but this is not yet a widespread practice, but it is gaining ground. Okay, what about the LCL? Okay, so the LCL, this is, you know, obviously originates on the lateral femoral condyle and then attaches on the fibular head. So one thing to keep in mind in regards to the LCL is this is an extracapsular structure, right? So it's not actually a part of the rotational component of the knee. Sorry. So sorry, guys. So isolated LCL injuries are actually a lot more uncommon, but when they do happen, these typically happen due to a high energy Varus force. So they get hit from the inside, causing the knee to essentially be wedged open laterally. Okay, so that's a Varus force. So one thing to keep in mind is that, generally speaking, a high energy LCL injury generally can often involve instability of what we call the posterior lateral corner. We'll talk about that more later. That's a little bit more of an advanced concept, right? So generally speaking, someone with a high grade LCL injury is likely will also have gross instability of the posterior lateral corner, right? So something to keep in mind, right? And so remember, Varus stress now, okay, we need to do 30 degrees and 0 degrees, okay? And so someone with an LCL injury may present with laxity, okay? Something that's really kind of a new, kind of some emerging anatomy here, right? That's called the anterior lateral ligament, okay? And now people have kind of dubbed this as the new knee ligament, right? So there's emerging evidence, obviously, about this piece of anatomy, and it's called the anterior lateral ligament again, and it's found actually in a ligamentous complex that actually is continuous with the IT band. Okay, so the anterior lateral complex, right, is representative of essentially a three-layer structure. The outermost layer of the anterior lateral complex consists of the IT band, but then deep to that we also have fascia. But then at the innermost layer of the anterior lateral complex is the anterior lateral ligament. And just like the IT band, right, it actually has its insertion. So you can see here, it's highlighted in green in the picture, originates on the lateral femoral condyle, or epicondyle rather, and has its insertion not on the fibular head, but on Gerdy's tubercle, okay? And there's actually been emerging evidence and research that in patients with isolated ACL injuries, they've actually found tears of the anterior lateral ligament, right, within certain studies, excuse me, in greater than 50% of patients with an isolated ACL injury. So people have advocated for surgical repair of the anterior lateral ligament along with ACL reconstruction, but a kind of a unified and commonly accepted surgical approach to repairing this ligament has yet to be developed, at least one that's commonly accepted. So guys, that's it. That's the lecture. I know I went kind of fast here. We can kind of dip into this again on Friday when we get together in person again. But what I would like you to do again is obviously spend time with this, go over it, right? Make sure that you review this and write down any questions. Remember questions that you might have, and let's go over them together, okay? You guys, I appreciate all of you so much. Thank you for your patience this week. And I think that this is going to be enough to tide you over information-wise, at least for tomorrow, okay? And potentially into Friday. Thanks, guys.